All right. Hi, my name is Rachel Kadar, and today we're going to be talking about ultrasound and anesthesiology, pulmonary ultrasound. I have no financial disclosures. Today we're going to talk about a little bit of the physics of pulmonary ultrasound. We'll discuss lung parenchyma, and what I hope you will take away and remember is that A lines are seen in a lung that is well aerated, and B lines are seen in a lung that is not filled with air. So when the lung is acting like a solid organ, you will see B lines. We'll discuss pleural effusions, pneumothorax, lung sliding, which is what you will see when there is no pneumothorax, and lung point is how we diagnose a pneumothorax. And then we will end with talking about the obstetric use of ultrasound in anesthesia. Just to review a couple definitions, resolution is the ability to differentiate between two objects on the screen, and penetration is the ability to visualize deep structures clearly. So in general, the higher the resolution, the lower the penetration. This is important when talking about which probe to use. So reviewing the probes, here we see the abdominal probe, the phased array probe, and the vascular probe. So the abdominal probe has greater penetration. It can go deeper into the body, but you will therefore have a lower resolution. On the other extreme, the vascular probe has less penetration, but has a much higher resolution. If we talk about ultrasound waves and what that means the abdominal probe has a lower frequency, longer wavelength to look at deep structures, but has poorer resolution. And the linear probe has a higher frequency, short wavelength to look at shallow structures, but does have a high resolution. When using pulmonary ultrasound, I recommend using the linear array probe for pneumothorax. I think that higher resolution and lower depth allows you to really hone in on that visceral and parietal pleura and look for lung sliding. And for the phased array probe is the probe that I like to use for pleural effusions and lung parenchyma. I find that the way that the ultrasound beams exit the probe and then spread out is nice to get in between the ribs, and I like to use it for pleural effusions and lung parenchyma. When we talk about lung ultrasound, it's important to note that lung ultrasound is based on an interpretation of artifacts produced at the pleural surface. This is important to know because we want to use those artifacts and see those artifacts. So in that regard, we do not want to use cardiac mode because cardiac mode, at least on our sonocytes, will try and get rid of all of the artifacts so that you can better see the heart. So when we are doing lung ultrasound, we want to put ideally the probe in lung mode, or sometimes I will recommend abdominal probe, as in for pleural effusions. But generally, when we're looking for A lines and B lines, some of these artifacts, or for lung sliding, lung mode is going to be the best mode to view this in. The pleural line is going to be hyperechoic or bright white, and it's going to be what generates most of these artifacts. So this is important when we talk about how to position the probe. We want to position the probe in a way that makes that pleural line as bright as possible, which is usually going to be horizontal across the screen. Again, artifact examples we're going to talk about are lung sliding, which is the seashore sign or that movement back and forth. The seashore sign is what you'll see on M mode or motion mode if there is lung sliding. We'll talk about A lines, which are going to be horizontal artifacts that we said means the lung is filled with air, and B lines, which are our vertical artifacts that mean that the lung is acting like a solid organ. Why do we do lung ultrasound? Studies show us it helps differentiate the cause and dyspnea. It can be better than the physical exam. So COPD doesn't always wheeze, CHF doesn't always have crackles. In addition, I like to use lung ultrasound in the intensive care unit to see how my patient is progressing day after day. If I'm diuresing them, how do my B lines look? How are my pleural effusions? Am I moving in the direction I'd hoped? And does that correlate clinically with how the patient's doing? Two common protocols that I like to use that use lung ultrasound are the blue protocol and the falls protocol. The blue is the bedside lung ultrasound in emergency, and the falls is the fluid administration limited by lung sonography. I recommend that you take a look at both of these protocols. When talking about the bedside lung ultrasound in emergency or the blue protocol, This is the protocol I use to determine where to ultrasound. So this protocol uses an upper blue point called the anterior, a lower blue point, anteromedial, and a prelapse point or posterior point. You can see this upper blue point is kind of here, midclavicular. Orientation of the probe is going to be indicated towards the patient head or cephalad. So if you see this picture over here, you can see that the indicator is oriented such that it's towards the patient's head. And the anteromedial, you're going to come just lateral, kind of just around the nipple line in males. And for the prelapse point, we're going to be in the posterior axillary line, indicator again towards the patient's head. And you're going to be very close to the bed. You're almost kind of flat against the bed and parallel to the bed. So again, thoracic ultrasound using this blue protocol, if we review these points again, one other way to find the points is to put two hands on the patient's chest, as seen here in this photo. If you do that, that upper blue point will kind of be where the fingers meet the palm. And the lower blue point will be the center of the palm, again, kind of right around the nipple line in males. And the prelapse point will be, again, that posterior axillary line, or maybe even a little posterior to that, parallel along the bed. So when I'm looking at these points for lung parenchyma evaluation, so when I'm looking at does the lung have A lines or B lines, is it full of air or acting like a solid organ, I'm going to use the upper and the lower blue points. And what I find at those four locations can help me with my differential diagnosis. When looking at pneumothorax evaluation, I'm going to start at that upper blue point. So again, that second intercostal space or so midclavicular line. When looking at pleural effusions, I'm going to be looking at that prelapse point, and we're going to want to make sure that we always see the diaphragm in the pleural effusion evaluation. So the anatomy that we're looking for when we see the ultrasound is shown here. These ribs are going to be calcified or hyperechoic. So you see kind of this rib arch right here, and they're going to create a shadow. So then you see this black shadow down here. And on this side, you see the same, the hyperechoic rib and the bright shadow. And that pleural line is going to be between the two rib shadows. You should see a bright white line. And this is the visceral and parietal pleura together. Again, they appear as that bright white line. Sometimes people will call this the bat sign, with the pleural line kind of being the pleural line being the bat, and the bat's wings being the ribs and the rib shadows. Just a reminder that normal lung is going to be well aerated alveoli and thin interstitial tissue. So normal lung will be filled with air. When we start to talk about the artifacts, one artifact is A-lines. And what this artifact is a reverberation artifact of the pleura. So ultrasound does not travel well through air. These sound waves will be scattered. And so I like to think of it as the ultrasound beams come down, they hit that visceral and parietal pleura. They don't enter the lung, but instead go back to the probe. And they keep going back to the probe and back to the probe. And I kind of think of it as if you're seeing the visceral and parietal pleura again and again and again and again, because the lung is not really absorbing any of those ultrasound beams. It's filled with air, it's reflecting those beams, they scatter out. So A lines are horizontal lines. They are parallel and equidistant from the pleura. And again, this suggests dry interlobular septa. So it tells us that the lung is filled with air. And this is pretty sensitive. This has a 90% sensitivity for a pulmonary artery wedge pressure less than 13. So here, again, this is in a linear probe, and I recommend using the phased array probe, but you can see a rib and a rib shadow. You can see that visceral and parietal pleura. You can start to see some A lines. But here is generally going to be what I would recommend you look for with the phased array probe at an increased depth, and you see an A line, A line, A line, A line, A line. And I do recommend you orient the probe so that you see them come all the way down to the bottom of the screen. B lines are also artifacts but they are slightly different. They are called comet tail artifacts or lung rockets. And they appear when the lung is not filled with air, or really when the lung is acting like a solid organ. So this can be with pneumonia, this can be with pulmonary edema, this can be with interstitial fibrosis. And here we see these are vertical lines. So here's the rib and the rib shadow over here. On this side, a rib and a rib shadow. And then here we see these vertical lines. They extend to the bottom of the screen to a depth of greater than 18 centimeters. This is important because this is why when you do lung ultrasound, I recommend that you increase that depth. You increase it to 15, 17, 18. The reason is there are things called Z lines that can peter out at around 7 centimeters. So if you don't increase that depth and you see B lines, you might not know if they are B lines or Z lines. In addition, increasing that depth, I think, and making sure whatever artifact you're seeing goes to the bottom of the screen ensures that you are appropriately angled on the chest and at the appropriate angle of insonation, such that you're getting the appropriate artifacts to come out. So again, these B lines will extend to the bottom of the screen. You should have that increased depth. They will move with the lung movement. They will interrupt any A lines, so you might see your A lines and then have these B lines coming down through it. Occasional B lines are normal, so one or two kind of going through your screen, not a big deal, but more than three is pathologic and therefore considered a B profile. So again, that angle of insonation and that probe positioning is really important. You need to see A lines or B lines because remember, we are wanting to line up appropriately to the pleura to get those artifacts to come out to tell us about the lung. So I always say, if you see nothing, it means nothing. So again, if we're in that upper blue point indicators towards the patient's head, the first step I'm going to do to get these artifacts to come out is generally rocking the probe. So rocking is moving in this orientation of the marker, and I'm rocking in order to get that pleural line horizontal. Because if I don't see a nice bright white pleural line and it's not horizontal, I'm not going to be able to optimize the artifacts, the A lines or B lines. Once I get that horizontal, then I'm going to tilt the probe, which is going to be in this direction, in order to get those A lines or B lines to come out. Remember, I think of those two lungs kind of like two 2-liter Coke bottles. So when you move to the lateral or the anteromedial, this blue point, the lower blue point here, you might need to tilt more such that you are perpendicular to that visceral and parietal pleura. So it might be a more extensive tilting to get those A lines or B lines to come out. So then when we use the blue protocol, we have a location of A lines and B lines, and where these are found based on those 4 points can suggest our diagnosis. So we have the A profile where we have A lines throughout, the B profile where you have B lines throughout, or the AB profile where you have a mixing of A lines and B lines. Remember that interstitial thickening due to fibrosis can also create B lines. So people talk about B lines, pulmonary edema. Doesn't always mean pulmonary edema. So you could have a B profile due to interstitial thickening. And then focal B lines, like this AB profile over here, are going to suggest pneumonia. So if we go through this AB and AB profile, we can look at what possible diagnoses we might be looking at. So positive indicates a potential diagnosis. Negative indicates the diagnosis is ruled out. I think for some of these, they are ruled out. For others, maybe it's a little overreaching to say they're ruled out, but let's go through each one. So the A profile, the patient can certainly have COPD or asthma. Again, the lung is just filled with air. They could also have a PE, and they might have a posterior pneumonia, because remember, this isn't looking in that PLAPS point. But if you see an A profile, you have nearly ruled out pulmonary edema as their main etiology, of course, of shortness of breath. If they have A lines throughout all the upper and lower blue points, it's very unlikely the patient has pulmonary edema. If you have the B profile, of course, pulmonary edema is very high on our differential and something we're concerned about. They say you ruled out COPD or asthma. Again, it's unlikely because it's not your top differential diagnosis, but it doesn't mean you've necessarily ruled it out. Same with PE. Again, you could have pulmonary edema and a PE, but you have really ruled out a pneumothorax. If you see those B lines, that indicates that there is lung sliding there. You've ruled out a pneumothorax. AB profile. Again, this is most likely pneumonia when you see these focal B lines on one side of the lung, but not the other. I agree that this has likely ruled out pulmonary edema because if you have A lines at the base of the contralateral lung, then pulmonary edema is usually going to be bilateral. COPD or asthma, again, you could still potentially have COPD or asthma, but it's certainly less likely the cause if you have focal B lines. There's just some more pictures. A lines, the horizontal repeating lines. Here you can see some A lines as well. I like to point out these two pictures of B lines because they're using different probes. So the top picture is using the phased array probe. You can see it's a smaller footprint, a rib shadow, a rib shadow. Here's your visceral and parietal pleura. You're looking at one intercostal space, and you can really kind of count those B lines. This might be 3 or 4 together. Versus here, this is the abdominal probe. So it's a bigger footprint, goes over multiple rib spaces, rib shadow, rib shadow, rib shadow. Here's your visceral and parietal pleura, and you can see that there's kind of a huge B line. It's a bunch of B lines kind of shoved together to look as one bright line, but this is certainly would be considered more than 3 B lines, and this is a B profile. But I don't think you can count them as much. And so if you were doing them over time, I find the top probe to be easier to see how the patient's improving, hopefully. So again, A lines or B lines. A lines are the repeating horizontal lines. B lines are those transient vertical lines. A lines are parallel and equidistant from the pleura. B lines are going to be those white lines that go from the pleura to the bottom of the screen. That's a reminder to increase that depth to 15, 18, 21. A lines are often a normal finding. It means that the lung is filled with air. B lines less than 2 can be normal, but more than 3 is pathologic. A lines suggest dry interlobular septa. B lines suggests what we call diffuse alveolar interstitial syndrome. So again, it's just something in the alveoli or the interstitium. So whether that's thickened interstitium or a pneumonia is filling up the alveoli or ARDS, it means that the lung is filled with something that's not air. So ARDS or pulmonary edema. And then A lines are prominent in atelectasis, asthma, or COPD. For B lines, focal B lines suggest pneumonia. So here again, you have your rib and your rib shadow, your rib and your rib shadow. Here's that visceral and parietal pleura. Here you see the A lines equidistant. Here you see a visceral and parietal pleura, and you see these B lines coming down. Now we're going to move on to talk about pleural effusion. So the most common causes, of course, are volume overload, congestive heart failure, pleural pulmonary infection. We can use thoracic ultrasound. It's safe, non-invasive bedside procedure to diagnose and classify our pleural effusions, and it's important during thoracentesis and chest tubes to increase safety and decrease complications. Here is a chest x-ray showing a pleural effusion and an ultrasound. Of course, CT is the gold standard in pleural effusion diagnosis, but it's costly. It's not always easily accessible. Chest x-ray findings will show here the costophrenic and cardiophrenic blunting and lung opacification, but ultrasound is actually shown to measure the effusion size much more accurately than radiography. In addition, I've seen many chest x-rays that the read says likely pleural effusion, and I go to ultrasound and there's not very significant one. And I've also seen chest x-rays that show the opposite, where they say they look relatively clear, and then you take a look and there's actually quite a large pleural effusion. So if we look here at this ultrasound, when we're doing pleural effusions, we always want to see the diaphragm. Kind of helps us orient and see what we're looking at. So here's the diaphragm. Here's the liver or spleen, depending on which side we're on. Here's the edge of the lung, and you can even see some B lines here in the lung. And then here is the pleural effusion right here. When we want to find that probe positioning, I generally am in the position here in D. So again, I'm in that prelapse point, really posterior, almost parallel with the bed, indicators towards the patient's head. But they show A, B, and C to kind of show how it's important to find that diaphragm. So in this scanning technique, they start with the probe indicator oriented this way, and they scan up and down this way to find that area where they see the diaphragm. And then once they find it, they rotate so that the indicator is now towards the head or cephalad. In E and F here, if the patient's sitting up, you can see that you can do it posterior as well. Again, making sure that you are at a location where you can see the diaphragm in order to orient yourself. So when we do the thoracic ultrasound of a pleural effusion, the fluid is going to be black or anechoic. So in this picture right here, we see a diaphragm. We see, again, liver or spleen. Here is our lung. It looks consolidated. It looks almost like a liver. And then you see, here's your pleural effusion, this anechoic fluid right here. Generally, you'll be in body mode with the indicator on the left side of the screen, and the indicator should be towards the patient's head. So this picture right here is actually swapped from how you should ideally see the picture, but sometimes people will take them that way. There are many different ways that you can measure the fluid. I like to just simply look and measure the distance from the diaphragm to the lung. I think this is an easy, quick way to kind of gauge, is my pleural effusion getting bigger or smaller? Is it large enough to need a thoracentesis or a chest tube? Anechoic fluid effusions, so the black can be transudate or exudate, but homogeneous echogenic effusions suggest a hemothorax or empyema. So if it's gray throughout, echogenic, meaning like isochoic or gray and not black or anechoic, then that might be a hemothorax or an empyema. So if you take a look at this picture right here, this is actually going to be swapped from the picture in the upper right, but this is how we would usually orient our ultrasound probe and see if you can identify the diaphragm and the lung. So there you see, again, the diaphragm right here, the organ, either liver or spleen. Here's the consolidated lung, and here's your pleural effusion. Let's look at some videos now. So again, we have the diaphragm right here. We have the liver or spleen. And then here you can see the lung kind of, I think of it as like waving in the wind, the tip of the lung. And then here we have a large pleural effusion, all this black around here. And as the patient breathes, and that diaphragm moves a little bit, you can see the lung kind of, again, peek out and wave at you. And I would consider this a large pleural effusion. Here's another image. Again, this is actually oriented opposite of how I would recommend. Here's the indicator on the left side of the screen. So this should be towards the head, but it's instead towards the feet. Again, you have the abdominal organ. Looks like spleen. Here's your your lung here is consolidated, and you see a large pleural effusion here surrounding the lung. So another example of a pleural effusion. This is just to note the difference in appearance of various substances between the lung and the diaphragm. So again, these look kind of different than our other picture where we see these areas of hyperechoic or white or stranding here. So this is an example of an empyema. Again, you see all this excess imaging in here rather than just the black pleural effusion. This is a complex septal pleural effusion. So here again, we see these lines or adhesions. And this one is actually a hemothorax because it's all isoechoic rather than black. Sometimes your pleural effusion can look isoechoic if it's overgained. So just make sure that that gain is decreased if you think it starts to look a little grayish. This can be important too for diagnosis, of course, and management, because if it's just a basic pleural effusion and it's bilateral, I might just be diuresing the patient versus if there's adhesions, then I'm more likely to place a chest tube because they're going to need potential DPA, TPA, and Dornase or other interventions. The curtain sign is essentially what you will see if you're looking for a pleural effusion and there isn't one. So it's an ultrasound finding in the inferior aspect of the lung field. Again, it's usually a normal finding when you're looking for the pleural effusion. So in these other images, we've seen the diaphragm and the lung, the tip of the lung in black. But in a normal, well aerated lung, that lung should be inflated and right up against the diaphragm. And we said that the ultrasound beams don't like air. So they won't necessarily go through that lung if it's well approximated to see the liver. So what you will often see is part of the diaphragm, part of the liver, but then you'll see this, here's your visceral and parietal pleura kind of coming across as the patient breathes and obscuring your view of the liver or the spleen. So this is what that looks like on ultrasound image. You see that liver, and then when the patient takes a breath, that ultrasound, the lung is coming across and kind of like a curtain obscuring your view of the liver. So again, you see here is your diaphragm right here, and when the patient breathes, that lung comes across. And if we were at the perfect angle of insonation, when that lung came across, we would probably also see that visceral and parietal pleura in A lines or B lines. Here, probably A lines because it appears to be well aerated. The only reason we don't see that again is because we're not perfectly lined up. But this is the curtain sign that tells us that the bases are well aerated. Moving on to talk about pneumothorax. The focused assessment with sonography and trauma, or the FAST, has been renamed the EFAST, and the E represents extended views, including the lung views. So ultrasound has a higher sensitivity than chest X-ray and a similar specificity. I prefer to use the straight linear high frequency probe that's pictured here. Some people do use the phased array, but again, I like that higher resolution. I don't need that depth because I'm just focusing in on that visceral and parietal pleura when I'm diagnosing a pneumothorax. Probe positioning, again, this is going to be that upper blue point. This is a zoomed in picture, so it's hard to see, but this is the patient's chin. There's the nipple. So we're here, again, anterior chest wall, second intercostal space, mid-clavicular line, or maybe even if anything, a little medial or closer to the sternum. Sagittal orientation with the probe marker towards the patient's head. Again, the anatomy, this is with the abdominal probe, so it's going over multiple ribs, but you see the rib shadow, the rib shadow, and you're trying to find that pleural line, that bright hyperechoic line in between the two ribs and the rib shadows. And you want to orient so that that rib actually does create a shadow. If not, you're not at that appropriate angle. Here's again how that looks with a higher resolution probe. So again, we can actually see the subcutaneous and the chest wall muscles and the ribs. And again, that pleural line is just underneath those ribs. And so usually you don't see the line under the shadow, but here we just have such a higher resolution we can. So when we look for pneumothorax, we're looking for lung sliding. And that's the to and fro movement of the visceral pleura on the parietal pleura with respiration. So it kind of looks like a shimmering pleural line or kind of ants marching. And if you see lung sliding, this rules out a pneumothorax. If you see lung sliding, this rules out a pneumothorax. So you can say there is no pneumothorax. The visceral and parietal pleura are well approximated. So when we do this lung exam, again, we are at I start at the upper blue point, indicator towards the patient's head. I like the vascular or the linear array probe. I see my pleural line. I see a rib and a rib shadow. Here's going to be where the lung would be. And when I have a pneumothorax evaluation, it's usually because I've heard decreased breath sounds. Maybe there's elevated peak pressures. I have concern. And so I'm going to place the probe on the chest and look for lung sliding with my ultrasound. Again, that lung sliding we said is going to look like that shimmering at the pleural line, like those ants marching with the linear array probe. So if we look for that and say, do you see lung sliding in these two videos? Again, you look at the video on the left. Here's the visceral and parietal pleura. Here is the visceral and parietal pleura, or that pleural line. So if you look on the video of the left, you do see lung sliding. You do see the ants marching or the shimmering at that visceral and parietal pleura. Again, this rules out a pneumothorax. There is no pneumothorax. However, on the right, you see no lung sliding. So again, this means possible pneumothorax. It means that there's something between or separating the visceral and parietal pleura. Whenever I'm doing lung sliding, I also always go on and place M mode or motion mode across the visceral and parietal pleura, across that mode. And when I do M mode, if you remember, M mode is motion on the y-axis over time on the x-axis. And if you get this tracing, this is called a seashore sign. And this tracing rules out a pneumothorax. So here's my pleural line, and we sometimes call this the seashore sign because it looks like waves on a sandy beach. And what this really is that M mode or motion mode is going through the motionless part of the chest above the pleural line. So you don't see any movement, you just see these straight lines. But if the visceral and parietal pleura are well approximated, they'll have that lung sliding, and the ultrasound beam will sense that movement of the lung if the visceral and parietal pleura are well approximated, and it will sense that movement, and you will get this artifact or this granular pattern here. So the lung sliding below the pleural line will create this granular pattern. And again, we call this the seashore sign. This represents waves crashing on a beach, and this rules out a pneumothorax. On the other hand, if you put M mode or motion mode and you see the stratosphere sign or the barcode sign, where you see the straight lines both above and below the pleural line, this means that there's no lung sliding. And so this means possible pneumothorax. So this is absent lung sliding. If it's in a pneumothorax, it's due to air separating the visceral and parietal pleura. But again, anytime you have anything separating them, you will see no lung sliding. So it could be a bad pneumonia, it could be the patient just had a VAT, there could be other things that are separating those. But of course, in the right clinical context, pneumothorax is high on your differential. So again, in M mode or motion mode, you will see horizontal lines both above and below the pleura. You won't see that artifact below the pleura because the ultrasound beam is not sensing that movement of the lung. And again, this is called a stratosphere sign or barcode sign because it resembles a barcode. There is also something called a lung pulse, and this is when you put M mode or motion mode. So here is that motion mode tracing. Here is the visceral and parietal pleura. You can see the rib and the rib shadow. Here's that M mode or motion mode going right where I would place it, which is across the visceral and parietal pleura. This is where you look at your lung and you don't see lung sliding. You don't see that movement at the visceral and parietal pleura. You don't see that shimmering, that ants marching. And when you put it in M mode, it looks what I call a little barcode-y. Like it's not a true barcode, but if you look at these lines down here and these lines up here, it looks similar to a barcode, but it's not really the barcode sign. And what this is this is a lung pulse. So this is where you have movement at the pleural line due to cardiac activity. So if you look at this tracing, you see there's your pleural line. There is that movement. This is that movement that you're seeing that's due to the heart or the cardiac activity. And so you see it throughout, and that's that beating of the heart. So this can be seen in apnea. So the patient's not breathing. So you're not seeing lung sliding because the patient's not breathing, but you are seeing a little bit of movement when the heart beats. So that tells you that the visceral and parietal pleura are actually well approximated. You're just not ventilating that lung. So again, this is seen in apnea, pleural effusions, and most notably, I think in anesthesia, or at least an important aspect would be a right mean stem intubation. So if we go back to this picture, we see those little areas where you do see the artifact, where you see these lines. But in between those artifacts, you see areas that look barcodey, right? They look straight across. You see those lines. And then if you look here, you see a barcode again. And here you see a barcode again. So the barcode tells us that the lung is not being ventilated, but the intermittent cardiac activity that we see in M mode tells us that we actually don't have a pneumothorax. It rules out a pneumothorax because when the heart beats, the lung moves a little bit and the ultrasound senses that movement. So the fact that the ultrasound beam can sense that movement tells us that the visceral and parietal pleura are actually well approximated. So a lung point, different from a lung pulse, a lung point is specific for a pneumothorax. So this is how we can say you definitely have a pneumothorax. So this is actually the border of the pneumothorax. This is where you see intermittent lung sliding, meaning you see lung sliding on one side and not on the other. So if you can get the right M mode, you might see alternating seashore and stratosphere patterns. And this is 100% specific for pneumothorax. This is not always seen in a pneumothorax because it can be difficult to find. So if I see no lung sliding on the ultrasound, I will move down the lung in search of the lung point. If I move down one rib space and now I see lung sliding, okay, maybe I have a pneumothorax, but it's small. It's certainly not a tension pneumothorax. It may or may not be clinically significant. But if I move down and I don't see one, then I'll move a little lateral, then I'll move down, I'll move lateral. If I get pretty far down and laterally along the chest and I still see no lung sliding, and I have concern clinically for a pneumothorax, then that is concerning to me. I'm worried that I have a large pneumothorax, maybe a tension pneumothorax, and I will quickly leave to prepare for a decompression if I'm worried about a pneumothorax. So again, a lung point that's more lateral and posterior correlates with a larger pneumothorax. So here is what that lung point looks like, where you see lung sliding on one side of the screen, but not on the other. Here is that visceral and parietal pleura. It's all the way at the top of the screen. This is using that phased array probe. So again, this is kind of, I think, a little harder to see, which is why I don't like the phased array probe. But if you look where that arrow is, you can see that shimmering or that lung sliding only comes up to a point about the point of that arrow. And then on the right side of the arrow, you don't see that lung sliding. So this is a lung point. This is actually the border of a pneumothorax, and this is specific for a pneumothorax. We do have a pneumothorax. Here's another example. I like this one more because it's with the vascular probe. It's more zoomed in, but you see here's your visceral and parietal pleura. Here's your rib and your rib shadow. We don't actually see it on the other side, but if you look closely, there is your lung point on the right side of the screen. We see that visceral and parietal, that sliding or that movement along the visceral and parietal pleura, and on the left side of the screen, we do not see that lung sliding. So again, this is the lung point border of the pneumothorax, specific for a pneumothorax. So again, a lung point that's more lateral and posterior equals a larger pneumothorax. So again, I start at the upper blue point, looking for lung sliding. If I don't see it, I will move down. If I don't see it, I'll move lateral, and I'll keep marching my way down and lateral to see if or when I see lung sliding. And of course, the further down and lateral I get with no lung sliding, the more concerning for a large pneumothorax in the appropriate clinical setting. Here is an example of the lung point on M mode. So again, you see the barcode sign on this side, and you see the waves on a sandy beach on the other side, or the seashore sign. So again, just to compare that M mode, here's your visceral and parietal pleura on both sides, and you are looking to see when you put M mode or motion mode along that line, what tracing do you see in M mode? And if you have the left is a normal lung, it rules out a pneumothorax. You see the seashore sign, and the right a barcode or stratosphere sign. Again, technically means possible pneumothorax, but you will see this, a barcode or stratosphere sign, if you have a pneumothorax. Tension pneumothorax is the accumulation of air under pressure in the pleural space. Essentially, you have damage. Air enters the pleural space, but it can't escape. This can rapidly progress to respiratory failure, cardiovascular collapse. On physical exam, we see unilaterally decreased breath sounds, distended neck veins, and a non-midline trachea. Most notably, your vitals, you'll see hypotension, tachycardia, and a narrow pulse pressure. Oxygen desaturations, a rise in airway pressures, and the treatment is going to be needle decompression. So you'll take a large bore, 14 or 16 gauge. You want a longer catheter, so 3 to 6 centimeter length angiocath. And you can do this midclavicular or anterior axillary space above the rib. It used to be recommended midclavicular, but now ATLS has actually recommended the anterior axillary space. Remember, you want to go above the rib because the neurovascular bundle is below, and you want to listen for that hissing because it just makes you feel better when you do your needle decompression and you hear this huge hiss or release of air. You know that you had the right diagnosis. You'll remove the needle, leave the angiocatheter in place until the chest tube can be placed, which should be placed immediately following. Here's two examples of a chest x-ray of a pneumothorax or a tension pneumothorax. You see here is a lung that is collapsed. We see air, and this is actually starting to push on the mediastinum. And here you have a change in a diaphragm depression due to that increased air. Again, the needle decompression locations, you can do midclavicular or anterior axillary. ATLS, as I mentioned, has recently changed to recommend anterior axillary. The reason behind that is in the midclavicular, sometimes if there's a lot of subcutaneous tissue, the angiocatheter might not make it all the way to the pleural space. I remember on trauma, many patients would come in with two angiocaths and they thought they'd done a bilateral needle decompression, but you go to do one with a larger angiocath and you hear a hiss of air. So sometimes that space isn't actually reached. If you're doing the midclavicular location, this is another easy way to quickly find it is the angle of Louis and then just go lateral, and that'll be your second intercostal space. So again, normal anatomy, the visceral and parietal pleura are well approximated. When you get a tension pneumothorax, air can enter the space due to tissue damage but not exit. Our causes are spontaneous or traumatic, and of course it can develop into a tension pneumothorax, which is most commonly seen after traumatic chest injury or those using mechanical ventilation. Symptoms we all are aware of, and then treatment is going to be a needle decompression. This is a Stanford emergency cognitive aid for all of our anesthesiologists, and it's put together of all the emergencies that anesthesiologists should be aware of and able to treat. And if you go through the treatment, again, you're going to increase the 100% O2, high flow. Rule out, of course, a mainstem intubation. So remember, if it's a mainstem intubation, you won't see lung sliding on the lung that is not being ventilated. But if you put it in M mode or motion mode, you can evaluate the tracing and see if it's a true barcode sign or if it looks, as I kind of comment, kind of barcodey-ish, and it looks like there is some actual artifact from the heart or the lung pulse. Consider ultrasound or stat x-ray. Do not delay treatment if the patient's hemodynamically unstable, and they still list the midclavicular second intercostal space as the area to place a needle decompression. This is the blue protocol, the bedside lung ultrasound in emergency. And I just like to point out, it's great to review on your own, how at the end we have different diagnoses. So pulmonary edema, PE, pneumonia, COPD, pneumothorax. So we can use what we see on our lung ultrasound to help us guide us down different routes. So again, if you see lung sliding and a B profile, we're highly thinking pulmonary edema. If you see lung sliding in an A profile, we might go down our other routes, pulmonary embolism as a reason for their shortness of breath, or maybe there's a pneumonia in the posterior area. They could have COPD or asthma. Any can have pneumonia, of course. And then if there's no lung sliding, but there's a B profile, that fits with pneumonia. So it's also another way to distinguish pneumonia from pulmonary edema. It's not always easily identifiable or clear, but if you see nice lung sliding, that can be more likely pulmonary edema. And if you don't see lung sliding, that is often more likely pneumonia. And then A profile, of course, if you have the lung point, you know it's a pneumothorax. But remember, just because you don't see lung sliding doesn't mean there's definitely a pneumothorax. So without the lung point, you need more imaging modalities. But of course, in the right clinical context, if you're worried about a tension pneumothorax and you see no lung sliding, pretty low and lateral on the chest, that would fit with a tension pneumothorax. Use of ultrasound and obstetric anesthesia, spinal or epidural anesthesia, abdominal blocks, vascular access, gastric volume status, transthoracic echo, and lung evaluation. In obstetric anesthesia, they're often using the ROSE scan, which stands for Rapid Obstetric Screening Echocardiography. A is acceptable and applicable. B is a bedside test at the left-hand side of the woman, which is how I recommend and teach you guys to do. Comfortable is C, comfortable and concise examination. So they focus on peristernal views and apical views for obvious reasons. The subcostal is more difficult. Diagnosis and response to therapy. So contractility status, volume status. Embolism, they talk about air, blood, amniotic fluid. So looking at right heart function and size. And F is for fetal heart rate assessment. This is an example of one of the popular um, ways to go down or pathway to look at for respiratory failure during pregnancy. Oftentimes they are looking at lung first, which I think is interesting. And they're saying, is the parenchyma normal or are there B lines? If they're B lines, unilateral again shows pneumonia. Bilateral, then they're looking at TTE filling pressures and saying if it's elevated, it's cardiogenic. If it's normal, it's ARDS. They'll look for pleural effusions. They'll look for a lung point. If there's no lung sliding, pneumothorax, lung consolidation. If they're static air bronchograms, atelectasis. If they're dynamic, it's more likely pneumonia. And then going down normal parenchyma, they're looking at TTE. Do you see RV failure? Maybe a DVT? Are we worried about PE? Is it normal? They'll call it a bronchial disorder, pericardial effusion, tamponade. So again, using what you're finding on ultrasound to rule in or rule out different diagnoses. This is a study looking at pregnant patients' lung ultrasound and looking at interstitial syndrome with severe preeclampsia. And so they were evaluating the role of lung ultrasound in severe preeclampsia. They saw interstitial edema in 5 or 25% of patients with severe preeclampsia, and they said that this did predict increased filling pressures. So their conclusion was that in patients with severe preeclampsia, lung ultrasound depicts both pulmonary edema and increased left ventricular and diastolic pressures, and implies that the use of IV fluids in patients with severe preeclampsia developing a B pattern should be discouraged. So again, we talked about the physics a little bit of pulmonary ultrasound, how it's an artifact. We talked about identifying lung parenchyma, A lines and B lines. Remember, A lines, the lung is filled with air. B lines, it's acting more like a solid organ. We talked about pleural effusions, the curtain sign, pneumothorax, lung sliding is what we're looking for. If we see lung sliding, we've ruled out a pneumothorax. If we see the lung point, then we do know that there's a pneumothorax. If we see the lung pulse, again, that's the cardiac movement. We know that there's no pneumothorax, but that lung is not being ventilated. And we talked a little bit about the obstetric use of anesthesia, obstetric anesthesia use of ultrasound. Thank you very much.